Thank you, Shanda, for that very kind, generous introduction. I also want to thank Dr. Rogers and the staff here for the invitation to give this lecture, and also to all of you for showing up. I'm sure that lunch played no small part in your decision, but I do appreciate you being here. The presentation today is entitled Volumetric Assessment of Valvular Regurgitation, but I'll start with why I think it's important. Now, I don't have any disclosures. I do have three caveats. First is that I will probably go back and forth between end-diastolic dimensions and end-diastolic volumes, and I realize they're not the same. I will be talking about mitral regurgitation mainly, but the principles that I'll speak about apply to all forms of valvular regurgitation, including TR and AR. And then the final caveat is I probably have too many slides. I do want to make sure that we have time for questions at the end, so as time runs short, I may have to run through a few slides at the end. I also wanted to start the presentation by introducing you to two surgeons that you may or may not know. The first surgeon is Jim Claggett. This is a photograph of Dr. Claggett when he joined the staff in 1935 at the Mayo Clinic. He was an extraordinary man, very busy general surgeon and thoracic surgeon at Mayo Clinic. And during the war years, when the Mayo Medical Unit went to Europe, Dr. Claggett couldn't go because he couldn't pass the physical exam. And he stayed back at Mayo Clinic during World War II. And during that time, had really an extraordinary experience. He said, I can remember times, and this is from his memoirs, I can remember times when I had 90 patients on my surgical service at St. Mary's Hospital and another 40 at the Colonial Hospital. So when you think that your service is busy, reflect on what Dr. Claggett had during World War II. He also wrote this letter to a friend just as the war was ending in 1945. He said, I've been busy for the last 3 months, and he listed 250 operations on the right side. And you can take a look at the kind of practice that Dr. Claggett had. He said he did that in addition to the other general stuff that I usually do. So this was an extraordinary man who also did coarctation repair and BT shunts, by the way. But the reason for talking about Dr. Claggett is not because of all the awards and honors that he received, but it was because of a patient that he operated on, a young man. Actually, the man was from Houston, and came to the clinic, was found to have a duodenal tumor, probably a periampullary tumor. Dr. Claggett did a Whipple procedure. The patient recovered. The family was extraordinarily grateful to Dr. Claggett and became friends. And so this family would vacation with the Claggetts in the summer, and the Claggetts would vacation in Houston in the winter. And they then came forward to Dr. Claggett and wanted to donate money to the Mayo Clinic because of their appreciation of the cancer care that he received. They offered, I think, initially $500,000. This is just before the war. And at that time, if you can believe it, the Mayo Clinic didn't accept donations from outside their clinical practice, and they turned him down. The family was undeterred in their interest in supporting cancer research, and they donated money and land to the MD Anderson. And the patient's name was Anderson. His father was James Anderson, and his uncle was Monroe Dunway Anderson. And the link doesn't really stop there, because when after the MD Anderson was opened, they asked Dr. Claggett if he would come up and be head of the MD Anderson Cancer Hospital, and he said that he didn't feel like he was qualified for that, but he did know one of his trainees who would be extraordinarily qualified for it, and that was Dr. Lee Clark. And of course, Dr. Clark was the head of MD Anderson for over 20 years, and the rest is history, as they say. The other person I wanted to introduce you to was to Dwight Magoon. And Dr. Magoon joined the clinic in 1956, and there are a couple of reasons to bring him to your attention. The clinic in 1956 is shown at the right side, on the right part of this slide, but like the Texas Medical Center, you couldn't find or recognize this building in Rochester right now because it's just overbuilt. But Dr. Magoon overlapped with Dr. Cooley in Baltimore. And here you can see a picture of Dr. Alfred Blaylock with two of what I would consider his best residents, Dr. Dwight Magoon and Dr. Denton Cooley. Also in the pictures is Henry Muir, who was chair of surgery at the University of Virginia, Willis Potts of the Potts Shunt, who was from the University of Chicago, and Rollo Hanlon, who was chair of the American College of Surgeons. Dr. Magoon was an outstanding surgeon, recognized for congenital heart surgery mainly, but he had a great career as a general cardiac surgeon with doing valve surgery. Actually, Dr. Magoon published a series of 100 consecutive aortic valve replacements without a death in 1965, 60 years ago. But the reason to bring him to your attention is because of his interest in mitral valve disease. And while Alain Carpentier gets lots of deserved credit for mitral valve repair, it was Dr. Magoon who did the first repair for a flail segment in 1958. Now, I met with many of the young faculty members and many of the young residents, and I thought it would be interesting to put the next few slides in. When Dr. Magoon passed away, his son, Mike Magoon, who was a cardiologist at Mayo, was going through his belongings and found this calendar. And you can see the date. It's from May 28, 1958. So he had been on the staff for 2 years. And think of yourself as young staff members. I see many people here who are probably right at that 1 to 2 year period in your careers. And this is what Dr. Magoon wrote on the back. Some principles that he resolved to carry out. And these are the principles that he wrote as a second-year staff person at the Mayo Clinic. He said, "I hereby resolve that I will exercise sober and intelligent reasoning as far from emotion as possible in arriving at decisions." The second thing he said, "I will discard unreasonable fear from prominent place during technical endeavors." And the third thing was that I will steadily accumulate and organize presently available knowledge to apply in the above decisions and techniques, that I will remain ever aware of the emotional and supportive needs of the patient, family, and referring physicians, that I am in every way endowed with the ability to carry out satisfactory surgical work, and that disappointments and reverses will occur in spite of this, which should not engender undue brooding. And finally, that I will not overcommit myself in such a way as to encroach on the ability to adhere to the above principles. Dr. Magoon was a remarkable man. So, the topic is volumetric assessment of valvular regurgitation. How is it helpful? Well, it can help you understand what's severe and what's not severe. It can help you understand when to operate and when not to operate. And why is that important? It can help you tell what happens to the ejection fraction after mitral surgery, helps you understand the difference between ischemic and organic mitral regurgitation, and volume overload due to multivalvular disease, and a few other things if we have time. In 1968, Dr. Magoon wrote a review article for the New England Journal of Medicine, and he was talking about valve surgery for mitral valve disease, and he said success of surgery establishes that treatment as indicated method whenever a patient shows progression into grade 3 disability in spite of good medical management. And that was at a time when regurgitation was determined mainly by contrast ventriculography. And it was conventional wisdom at that time that if you had severe mitral regurgitation, that it was tolerated well, and that patients with severe mitral regurgitation did well for many years. And that was until a natural history study was done by Maurice Serrano, where he looked at the natural history of flail segments. Now, this study was done without quantitative methods, but if you have a flail segment as shown here, where you have complete prolapse, you almost certainly have severe mitral regurgitation. And what he found from this natural history study was that patients who had severe mitral regurgitation had a survival that was reduced compared to expected. Now you might say, well, I might expect that. Well, think about this. These patients had good medical care. They were cared for at our clinic. They were seen by good cardiologists. They were operated on when symptoms developed by good surgeons, and yet their survival was still less than that of an age and sex-matched population. And by the end of 10 years, almost a third of the patients had developed atrial fibrillation and almost 2/3 had heart failure. So the notion that mitral regurgitation is tolerated well for many years was not true. Now, it turns out that if you operate early, in other words, in these patients that had severe MR, if they had an operation within 3 months of the diagnosis, their survival at the end of 10 years was almost 80% compared to 65% for patients whose operation was further delayed. So the story as it is developing is that when you operate earlier, the patients had a better outcome. And the difference was not due to selecting patients for surgery, it was due to the difference in cardiac-related deaths. In fact, if you operated on patients early and they had a normal ejection fraction, their survival was the same as an age and sex-matched population. Now, so the question is, if you have an asymptomatic patient, how do you know how severe the regurgitation is? And of course, then came quantitative methods, mainly with Doppler echocardiography. This just shows the PISA method. If you look at the area or the radius of flow convergent, you multiply that by a constant and the alias in velocity, you get a regurgitant flow rate. You divide that by the regurgitant velocity and you get the ERO. If you know the ERO and the regurgitant time velocity interval, then you can calculate a regurgitant volume. And all of this is known very well by cardiologists in the audience who know much more about it than I do. There's another way to measure regurgitation, and that's with the continuity equation. But the point is that with Doppler methods, you can assess the severity of mitral regurgitation, and you don't have to wait until a patient becomes symptomatic enough to justify an LV-gram. So then Maurice did a study of asymptomatic patients with mitral regurgitation and stratified them by their degree of valve leakage as assessed by the ERO. And you can see that if you didn't have very much mitral regurgitation, you were asymptomatic, your survival at 5 years was good, and it was much less good in patients who had EROs greater than 0.4. And an ERO of 0.4 correlates roughly to a regurgitant volume of 60 cc's. Now, this paper in the New England Journal, the New England Journal is not very favorable towards surgeons. And what they didn't recognize was they published a paper that was very pro-surgical, because in this study, the survival of patients who ended up having an operation was excellent. And the adjusted risk ratio of patients who underwent mitral valve repair was 0.28 compared to patients that didn't have surgery. And there are very few things that we do in medicine, cardiovascular medicine and surgery, that have that kind of impact on patient survival. So these numbers are familiar to all of you, and they're the general categories of mitral regurgitation as assessed volumetrically. So what do we mean when we talk about volumetric assessment? Well, if you have a regurgitant volume of 60, which is severe, and we see patients with regurgitant volumes of 80 or 90 even, but all of the patients that we operated on with degenerative disease almost always have a regurgitant volume of 60. And I use 60 as a nice round number, and I used an ejection fraction of 60 because it's a nice round number. Nothing that I'm going to show you is rocket science. It can all be figured out on the back of an envelope here. And a patient walks into your office, that means they have a forward stroke volume of at least 60. Everyone would agree with that, probably higher, but let's use round numbers. And that means they have a total stroke volume of 120, and if you have an ejection fraction of 60%, what does that mean? That means that you have an end diastolic volume of 200. Now, I'm going to leave that up there for a minute because everybody would say, yeah, that's pretty obvious. But what does it mean when you're seeing patients? Well, this is an echo report, and this is the way we teach our residents to go through echo reports. Is everything consistent? Is the degree of regurgitation assessed by these quantitative methods consistent with what you see? Well, this patient had an ERO of 0.7. He had a piece of regurgitant volume of 74. That's confirmatory. The left ventricular end diastolic dimension was elevated on this report. I didn't show the volumes, but he did have a large ventricle, and the atrium was enlarged. So everything here is consistent with severe regurgitation, and I suspect that everybody would nod, yes, that's severe MR. What's the big deal? Well, here's a case report that was submitted to the Journal of Thoracic and Cardiovascular Surgery. And it was talking about a technique for mitral valve repair, and it says transthoracic echocardiography showed isolated posterior leaflet prolapse with severe MR, regurgitant orifice 0.57, regurgitant volume 63. And they go on to say the left ventricle was not dilated with a preserved ejection fraction. Now, whoa. Can that happen? Can you have a normal ventricle? I used to have patients referred regularly and someone would say they have a normal ventricle and severe MR. You can't have a normal ventricle and severe MR. You can have a normal ejection fraction, but the ventricle has to be enlarged. So this paper didn't get very far. And it's not just surgeons who don't think about this. This is a paper submitted to circulation by a very well-known imaging group, and they were using cardiac MR to define early dysfunction in patients who had few symptoms with severe MR, and a very sophisticated kind of analysis of strain in patients. And they said left ventricular function as assessed by LV dimensions and ejection fraction was within the normal limits in all MR patients. Well, think about that. If you're thinking volumetrically, you'd say something's wrong. Either their assessment of the MR is wrong or their assessment of the ventricular dimensions is wrong, but you can't have a normal LV size and ejection fraction in severe MR. Not possible. Well, it can help you tell when to operate, and I'll give you an example. This is a case, a patient, asymptomatic woman from Florida who was being followed by her cardiologist at home, had initially moderately to severe MR, kept coming back for echoes, and the MR progressed. She had pretty good exercise tolerance on the treadmill, but the cardiologist was concerned, sent her to a surgeon locally who advised mitral valve repair. And she was anxious about this, so she went to New York City and got 2 more surgical opinions. Both advised surgery. In fact, one of the surgeons said, not only will I fix your mitral valve, I'm going to take a look at the tricuspid valve just to make sure that that valve's not leaking too. And that made her very nervous because she said, I'm asymptomatic. So when she came to us, she was asymptomatic, anxious. Here's her physical examination, EKG, labs, and so forth. BNP was normal. Here's her chest x-ray. Not very impressive for somebody with severe MR. So what's going on here? She has sort of bileaflet prolapse. You can see the MR jet here, vena contracta 0.6. And the transthoracic echocardiogram done at the Mayo Clinic showed bileaflet prolapse, again, normal ejection fraction, normal right ventricular systolic pressure. But it also showed an end-diastolic dimension of 49 millimeters and a normal left atrial volume. So what do you do? Well, if you're thinking volumetrically, you'd say this does not fit with severe mitral valve regurgitation. What's going on? Well, this is a phenomenon of late systolic MR, and you can see if the technician draws the envelope of mitral regurgitation, velocity envelope right here, it's different than this. If you draw the window here with late systolic MR, this is what you get, and it makes a difference in how you calculate, or the calculated volume. And so when the Doppler echo was done properly and done at Mayo Clinic, it turns out that the ERO was 0.29 and the regurgent volume was 35. So this patient clearly didn't need surgery at that time. Now, she may need surgery in the future. She's got bileaflet prolapse and she does have some valve leakage, but the natural history of mid to late systolic MR is pretty good. I mean, the chance of a bad outcome over the next 5 to 10 years is low, and it's quite different than holosystolic MR. But if you're thinking volumetrically, the fact that the LV size was normal will make you question the accuracy of that. Now, there are many different ways to get an assessment of MR, but this one was easily done just by repeating the echocardiogram and having someone experienced look at the Doppler profile. Now, this is another case that I think illustrates the value of thinking volumetrically. This is a man who had a bicuspid aortic valve with aortopathy, seen at Mayo Clinic. We advised surgery. For some reason, he didn't like what we had to say. He went to New York, had aortic valve replacement of the ascending aorta. Everything worked out pretty well except for the right phrenic. The reason he came back to us was that he developed fever, chills, and suspected endocarditis. He was initially febrile, had all the features of endocarditis. It looked like a terrible problem. He was hospitalized and treated with antibiotics. Here you can see that now he has mitral regurgitation. Now, the outside TEE showed no prosthetic obstruction of the aortic prosthesis, but moderately severe MR with an ERO of 0.36, regurgitated volume of 59, and an unusual retroaortic space behind the aorta. So it looks like a case of endocarditis, aortic valve, possibly graft infection, and now developed mitral regurgitation. He also had emboli, so everything fits with endocarditis. So we don't have an audience response thing, but think about what you would do for this man. You could complete, he's now 3 weeks into antibiotics. Would you complete antibiotics and do an AVR, mitral valve repair, complete the antibiotics, remove the graft valve, do the valve repair, complete the antibiotics, do the mitral valve repair, ... Think about what you would do here. Well, it turns out he was doing pretty well on antibiotics, and the thing that drove the consultation was this concern about the mitral regurgitation. And the report, I kind of hurried through it, but it said to show ERO of 0.36, regurgitant volume of 59, no vegetations. That makes sense. And then it said down here, normal LV size, ejection fraction, 65%. And if you're thinking volumetrically, that should raise a flag. You should say, well, wait a minute, that doesn't make sense. So this patient had another echo at our institution, and it turns out his LV and diastolic dimension was pretty normal, 51. And here's his Doppler echocardiogram. He got no MR. The valve looks fine. I can't explain why he had severe MR or had a severe color flow signal on his outside MR, but he clearly doesn't need anything done to the mitral valve. And you get onto that by thinking volumetrically. And it turns out that with antibiotic treatment, everything healed up. He didn't need replacement of the ascending aorta aortic graft and the aortic valve. Now, thinking volumetrically helps you in other ways. It helps you understand what happens to the ejection fraction after mitral valve surgery. Here's a patient who has severe leaflet prolapse, severe regurgitation, and we do a mitral valve repair. This is his pre-bypass short axis. The post-bypass ventricle doesn't look quite as whippy, doesn't empty quite as completely. So we get this as surgeons, we get this all the time. We're coming off bypass, we've just repaired the tricuspid valve, and the echocardiographer says, well, the right ventricle looks like it's down, right? Or you repair the mitral valve, and the echocardiographer says, it looks like the LV is down a bit. So what's the cause of that? Well, we talked about this some yesterday with the surgical resident. Is this increased afterload? Is this close a pop-off valve? That's a very common answer to the question. Another common answer to the question is that it unmasks LV dysfunction from chronic volume overload. That's a little more complicated, maybe related to number one, but that is another answer that we get often. Poor myocardial protection gets blamed for many things. It could be that it's poor myocardial protection. Now, coronary area embolism and circumflex injury is a real problem, but usually that gives you regional problems, so that really doesn't fit with what we see. And the answer that I get mostly from surgical audiences is this one: it never happens to my patients. But there's other explanations, and if you think volumetrically, you can figure it out. So let's go back to this construct that we had about volumes and regurgitation. So the patient has a regurgitant volume of 60, a forward stroke volume of 60, a total stroke volume of 120, end diastolic volume of 200, and we fix the valve. Now, I'm going to speak to the cardiologist in the audience. You want your patient to get out of the OR with a normal ejection fraction, right? Everybody wants that. And if you don't get it, they call you up and ask why. Well, here's why. If you had a normal ejection fraction, when you come off bypass, you still have an end diastolic volume of 200. The heart doesn't shrink right after mitral valve repair or replacement. The end diastolic volume is 200. And let's say you want that patient to have a ejection fraction is 60. They came in with 60, it ought to be 60 when they leave the OR. That means they have a total stroke volume of 120, and that gives them a cardiac output of 10 liters. Now that's unphysiological. That won't happen. You don't come out of surgery with a cardiac output of 10 liters per minute. So how does the heart adjust to have a normal stroke volume or slightly elevated stroke volume with an enlarged end diastolic volume? Well, it decreases the end systolic volume. Let me look at it another way. Let's say that you had an end diastolic volume of 200. You come off bypass, you've got an end diastolic volume of 200. And let's say that the patient's doing well, no mitral regurgitation. Are you with me? No mitral regurgitation. Let's give them a total stroke volume of 80. Remember, before surgery, it was 60. So now, coming off bypass, that's better, right? But if you have a total stroke volume of 80, end diastolic volume of 200, your ejection fraction is 40%. Your cardiac index is 5 to 6 liters per minute, pretty normal, maybe high normal. So is the LV down? Your ejection fraction is 40, but your cardiac output and your stroke volume are elevated. So think about that. The cause of a reduced ejection fraction is not because the heart's damaged, it's trying to adjust to a normal stroke volume in many patients. Now, there are other causes as well. Now, we did a small study just to look at this to see whether this whole theory was true. After mitral valve repair, there's no real important change in LV dimension. The ejection fraction does fall. And if you compare that to patients having surgical revascularization, actually patients that have coronary bypass surgery, it doesn't go down at all, it's up just slightly. But the stroke volume, even though the ejection fraction goes down, the stroke volume after mitral valve repair goes up slightly. So I think to state it again, that LV function early after correction of MR is that the ejection fraction decrease with an increase in systolic volume to preserve a normal stroke volume. And it's a compensatory mechanism to prevent excessive stroke volume. Now, if you still don't believe that, think about the right ventricle. Let's say that you want that patient to come off bypass with a cardiac index of 10 and a total stroke volume of 120. How is the right ventricle going to give you a stroke volume of 120? Is it going to enlarge or is it going to empty more? I mean, think about that one. It really can't do that. It can't go up to 120. Now, with time, that ejection fraction will improve. It improves more and more completely in patients who have relatively normal ejection fractions pre-op. If your patient comes in with a reduced ejection fraction, the chance of getting a normal ejection fraction 3 to 5 years later is almost zero. Now, thinking volumetrically also helps in thinking about the difference in ischemic and degenerative mitral valve regurgitation. And there's no question that the presence of mitral regurgitation is a prognostic factor for patients with heart failure. We have many experts in heart failure in the audience that know more about that than I do. The issue is, if you do something for the mitral valve regurgitation, does that make a difference? And it's been vexing for surgeons because we look at the outcomes of repair of degenerative mitral valve regurgitation and say we make a big difference when we correct that. But we don't make such a big difference when we correct mitral regurgitation that's functional. And it doesn't matter whether it's severe or not. This is the results of the CTSNet trial, where they looked at cumulative incidence of death in patients that had repair of mitral regurgitation versus those that had bypass alone. No real difference in the instance of death or cardiac events. So repairing mitral regurgitation that's ischemic in origin doesn't seem to give you the same bump that you get when you repair degenerative mitral regurgitation. And that's understandable if you think volumetrically. So let's consider a patient. Now, I know this is a bit extreme, but I'll use the extreme here because it works. Let's say the patient has an ejection fraction of 25%, a forward stroke volume of 50, reduced. The patient has heart failure, reduced stroke volume and no regurgitation. They have an end diastolic volume of 200. Now let's look at another patient who has the same problem. This patient had inferior MI and develops regurgitation. Now, what happens to the end diastolic volume? Well, if you start off with an ejection fraction of 25%, you have a stroke volume of 50, and you tell me that that patient is now in heart failure and I want you to fix it because they have severe MR, I'll ask you, what do you mean by severe? And if you say, well, severe, and I think of severe as 60. Are you with me? And if you have a regurgitant volume of 60 and a forward stroke volume of 50 because they're still alive, that means you have a total stroke volume of 110. And if you have a total stroke volume of 110, that means you must have an end diastolic volume of 440 cc's. Well, think about that. That means that the heart is out to here. You can't get severe mitral regurgitation, ischemic mitral regurgitation with a reduced ejection fraction that's volumetrically severe. So my suggestion to you is the reason we don't get as much, or we don't have as much impact on survival is because we're not correcting the same amount of mitral regurgitation. What happens is this patient who has no regurgitation and then develops severe MR will become so symptomatic when they get a 30 cc regurgitant volume that now they present with heart failure, and somebody said, well, it must be severe because they're severely ill. But it's not severe if you think about the volume of regurgitation. Now, again, it's not just surgeons who are guilty of this. This is a paper that's very popular, showing the results of the MitraClip, and they looked at all-cause mortality, and they found out that the MitraClip seemed to reduce mortality, all-cause hospitalization, that sort of thing. And here are the data. I know you can't read it back there. But if you think volumetrically, the first thing you do is focus on the echo report. And when we focus on the echo report in patients that got the MitraClip and the control patients, this is what you see. Very well balanced. It's a randomized trial, obviously. They had, are said to have severe regurgitation with an ERO of 0.4. They had an end-diastolic volume, end-systolic volume that are shown here. But if you think volumetrically, do the math. That means that the patient had an end-systolic volume of 135, an end-diastolic volume of 194. That means they have a total stroke volume of 60. Total, the mitral regurgitation and the forward stroke volume. So how much mitral regurgitation do they have? Well, I don't know. I don't know whether it's a problem with the way the quantitative studies were done at the core lab, or whether it's, I don't know what the answer to this is, but I can tell you that if you have a total stroke volume of 60 and you have mitral regurgitation, you can't have more than 20 because you have to be walking in the room. You have to have at least a 40 cc forward stroke volume. So if you start thinking volumetrically, you look for these kinds of things in publications. Now, there was a lot of publications after this when it was pointed out to the authors and the editors that this was a problem, and then they came out with this theory on proportionately severe MR, and that really never made sense to me. It didn't answer the question of why you only have a total stroke volume of 60 cc's. But let me give you a clinical example. This is a 71-year-old man who had bypass surgery in 2000, did well for 15 years, then had a myocardial infarction, was desperately ill. The vein graft to his OM was stented. He had a great result. They really salvaged this guy. Ejection fraction's 30%, had an ICD-10, did very well, and then he's referred now because his cardiologist said he's developing mitral regurgitation. And this is his echocardiogram, and you can see the mitral regurgitation here. This is the report, severe mitral regurgitation, 2 jets, ERO 0.48, pieces 82 cc's with regurgitant volume. So what are the next steps? This guy's had bypass surgery, has reduced LV function, severe mitral regurgitation. Would you just treat him medically? Do you need to get a TEE? Would you re-op and repair the valve or replace it? Would you do MitraClip? Well, think about what you'd do in your practice. Well, we went ahead and got an angiogram, and this is his angiogram. He had very severe native disease. He had a nice mammary to the LAD. A nice vein graft to his PD. And he had an occluded OM graft again. You can see the stent previously placed in there. Well, we did the coronary angiogram. What's next? What would you do for this patient? Well, I kind of hurried through this, hoping that you would think about the volumetric assessment, because If you have an ejection fraction of 30%, can you have a mitral regurgitation volume of 82? Well, if you do the math again and think about that, it's very unlikely that he had a regurgitant volume of 82. You need another assessment. Now, we could have gotten a cardiac MR or whatever, but this was actually all sorted out before the cath, and so we just asked for the patient to get a contrast ventriculogram. And here's the contrast ventriculogram. Now, does the patient have MR? Yes, but just a puff. Certainly not so much that would make you want to run in and do anything, whether it's a clip or an operation. In fact, medical treatment, this guy could get by well for a while. Again, I don't know why the other echocardiogram, the MR looked worse, but I think by thinking volumetrically, you can save yourself and the patient quite a bit of misery. So remember the key points here with volumetric assessment. It has to add up the regurgitant volume, the forward stroke volume, and the ejection fraction. If you think of those three things, I think it will be helpful to you in your practice. Remember too that early after correction of mitral regurgitation or aortic regurgitation or tricuspid regurgitation, the indices of systolic function decline, but this is mainly compensatory, not due to damage to the ventricle. And recovery depends on, or subsequent recovery depends on the LV coming down in size, at which time the LV ejection fraction will come up. I was thinking about this, I've thought about this a lot, and it occurred to me, there's one other explanation, or one other clinical scenario where thinking of volumetric assessment makes sense. And that has to do, we've talked a lot in our meetings with some of the staff and residents about hypertrophic cardiomyopathy. For those of you who see patients with hypertrophic cardiomyopathy, a very common clinical scenario is that somebody comes into you, they're 55 years old, they were doing well up until 2 months ago, and then they developed severe exertional dyspnea. They just can't do anything. And it's not just shortness of breath, it's profound fatigue. I mean, they have to take a nap in the afternoon, they just get worn out. And you do an echo, and they have obstruction and some degree of SAM-related MR. And it occurred to me that one of the reasons that these patients become so symptomatic is that when they develop obstruction, and when the obstruction worsens with exercise or provocation of one type or another, then they develop regurgitation that would only be called moderate. Let's say 30. But if you take 30 cc's away from somebody whose normal stroke volume is 70, and they don't have any way to have any compensation, then all of a sudden they feel awful because now their forward stroke volume is 40, not 70. So I think that that's one of the reasons for profound fatigability in patients that have intermittent symptoms in situations like hypertrophic cardiomyopathy that's SAM mediated. Well, anyway, I appreciate your attention during all this, and I'll be happy to answer any questions. Thank you.